me. Good evening. It's an honor for me to present Professor Klaud Miller, who is going to talk to us about tibial osteotomies, the inability of weight-bearing X-rays to predict accurate correction. You can see the resume on your invitation, but I will say a few words. Professor Klaud Miller is a clinical professor of surgery at Swedish Hospital, Chicago, and also the University of Nicosia Medical School. He is a board-certified orthopedic surgeon and the medical director of Windy City Orthopedics and Sports Medicine on the north side of Chicago for almost 30 years now. He practices at Swedish Hospital and St. Francis Hospital in Evanston, Illinois, and the North Shore Surgicenter in Lincolnwood, Illinois. His practice includes all aspects of orthopedics except spine surgery. His subspecialties include all aspects of sports medicine, arthroscopy, as well as joint replacement, hand and foot, and trauma surgery. He is a member of the American Academy of Orthopedic Surgery, the Arthroscopy Association of North America, the American Orthopedic Society for Sports Medicine, the American College of Sports Medicine, the National Strength and Conditioning Association, and the American Running Association. We will now proceed with the presentation and then take some questions. Professor Miller.
Thank you very much, Dr. Economou. I'm very happy to be presenting tonight. Can we get my slides up? My presentation up?
You will have to share again, Klaud.
Oh, I got to share again. Okay. All right. There we go. Okay. And you can see my arrows. Okay. All right. We're all ready to go. All right. So the purpose of my talk today is to present some of my work on tibial osteotomies. And the question is, why has tibial osteotomies gotten somewhat of a bad reputation? Are X-rays the accurate representation of our findings? This is the typical Varus knee on the left side where the arrow is. Bow-legged is Varus. Here's an X-ray showing the complete obliteration of the medial joint line. You can see what's called the anatomic axis here, a line drawn down the middle of the femur, a line drawn down the tibia, and the meeting at the center of the knee and measuring the axis. In this case, this is probably 15 degrees or so of Varus. This is what has certainly been the most common treatment for this. This is the common total knee with the patella prosthesis, the metal and polyethylene, and the femoral prosthesis for a completely eburnated bone. The articular cartilage is completely worn away. Now, the total knee is at the tail end of the treatment options. The easiest option is pharmacologic or regenerative surgery, anti-inflammatories, cortisone injections, sometimes bracing, physical therapy. Reconstruction is a unicompartmental total knee, a total knee. Osteotomies are somewhere in the middle here. You don't put in a prosthesis. If everything fails or if the revision gets infected, you're talking about a revision, total knee, and arthrodesis, and ultimately here's a standard total knee X-ray, a revision total knee, and ultimately knee fusion or even amputation. Now, what's the problem with the total knee? Total knees can wear out. If you look at the, what happened to my arrow here? Here it is. Okay, if you look at the, here is cumulative revision rates with time since the prosthesis, since the original surgery. You can see it's relatively low. If you're over 80 over 75, if you are less than age 55, the revision rate increases significantly with time. Statistically speaking, if you look at this, it's about 1% per year of follow-up. Obviously, it's better if you're over age 75, but that number actually works out pretty well. So what does the scientific literature show us on total knees? All right. you got to remember that the problem with long-term follow-up is these were procedures that were performed 20, maybe even 40 years ago. These are not, quotes, modern procedures in many cases. In many of these series, the average age was in their 70s, and originally there was some restrictions on weight. We thought that there was a higher failure rate if somebody was over 180 pounds. So many of these patients were more ideal candidates. And finally, there's relatively few patients that are still alive at 20 years for follow-up. So that may skew our rates. Here's a meta-analysis from 3 years ago from Lancet, 26 papers, including unicompartmentals, but there is still no series with over 25-year follow-ups. The estimated 25-year follow-up was 80%. This is where that 1% comes in. If the survival rates at 10 years are higher than they are at 25 years, but overall, the survival rate is approximately 1% per year since surgery. A failure rate is 1% per year. Whoops, 1 second here. Okay. Well, okay, here we go. Now, the unicompartmental is actually slightly less. Unicompartmental has gotten a lot of press lately about how it's so wonderful, but the literature would support that the survival rate is not as good. All right, what are potential reasons for needing another total knee? Infection is obviously the most severe, mechanical loosening, other mechanical problems, no apparent explanation for failure is 10%, dislocation in the knee. Obviously a hip is a significant problem, but in the knee it still happens, primarily patellar. Polyethylene wear, implant breakage, osteolysis, prosthetic fracture. This is coming out of the hospital for special surgery. Now, age is a factor. If you've got a younger person, you probably are going to have a higher risk of failure, as we showed earlier. So age needs to be considered. Body type needs to be considered. This is not going to be an easy total knee if this person needs a total knee. Plus, obesity is a risk factor for all reasons of failure. Wear of the polyethylene, certainly somebody who is this obese is going to tend to have a higher chance of arthritis at an earlier age. They may have other comorbidities from a medical standpoint. So this is not an ideal total knee candidate. What is an osteotomy? For the medical students, osteo or os is bone, otomy is cut, but you have to remember that not all things with OST are bone. Osteum is a hole. What are the principles for an osteotomy? You certainly have to have some articular cartilage remaining. If the cartilage looks like that slide I showed you at the beginning, that's not going to be a successful total knee or a successful osteotomy, and that needs a total knee. You've got to be able to produce a congruent joint. You have to have a good range of motion. You cannot have a fixed deformity. It may provide long-term relief, but it certainly may require further intervention, and at least hypothetically, further intervention may be more difficult. Revision surgery may be more difficult because of the hardware or the osteotomy, because the osteotomy is creating a slight deformity. The advantages of a tibial osteotomy: retains your own knee, better motion, no risk of prosthetic failure, can be revised to a total knee without complications, although some people would argue that this is not correct. No long-term risk of infection, which is obviously the biggest single problem with total knees. Disadvantages: probably not as durable as a total knee. There is a risk of a non-union, especially with an opening wedge technique. We'll discuss that in a second. Rehab is probably a little slower because you've got to wait for healing, although with current internal fixation techniques, I think that's a minimal problem. And it's only good for medial compartment arthritis. Does not work if you've got significant lateral compartment arthritis. What's the history of I keep saying total knee, tibial osteotomy? The first description was by Jackson in 1958. Our picture's cutting off a little bit. He came out with a very detailed description in 1974 and described both closing wedge and the barrel vault osteotomy, which we'll talk about in a second. Coventry in '73 kind of popularized it. That was kind of the a paper that opened up the the gate, so to speak. Maquet described the barrel vault osteotomy in his paper in Clinical Orthopedics in 1976. This was the first detailed description of the technique on the barrel vault osteotomy. All right, again, Varus is bow-legged, genuvalgum is knock-kneed, recurvatum means that the tibia, the knee hyperextends. So these are the three general descriptions of deformity of the knee. General Verum was a bow-legged Roman general. That's where it came from. Okay, how do we measure limb alignment? The mechanical axis is the line that goes through the femoral head, through the knee, to the ankle. And this line is the mechanical axis. This is where the weight comes through the leg. The anatomic axis is a line that goes through the middle of the femoral shaft to the middle of the distal femur, and the tibia, the intercondylar eminence, through the middle of the ankle. Now, so these are going to be measuring the body, but they are measuring it in different ways. If you have a valgus deformity, the weight-bearing line is going to go outside of the knee. If you have a varus deformity, the weight-bearing line, the mechanical axis, is going to go medial to the center of the knee. So what we're trying to do is we're trying to create the normal, slightly valgus alignment of the weight-bearing surface. Whether we measure this by an anatomical method or mechanical method, it's just different ways of measuring the same alignment. Okay, what are the surgical techniques? The closing wedge is the Coventry. We'll show that in a second. Barrel vault is the Maquet. Opening wedge has become popular very recently, and then we have all kinds of opening and closing combinations where we're doing all kinds of fancy carpentry, but we're all trying to achieve the same thing. We're trying to take the weight off of the inner side of the knee, which is the mechanical alignment, and put it on the, quotes, good lateral side of the knee. Here is the typical medial complete obliteration. Here is the Coventry technique, where you take a wedge out. This is obviously an old slide I stole from a book. And the wedge has been closed, and now we've got opening here, and we have, from a varus alignment, we're now slightly valgus alignment. Here are full-length x-rays showing the same thing. This is actually a Maquet osteotomy here, but it's achieved the opening the joint on the medial side. Here's a diagram of the Maquet osteotomy. You're making a curvilinear cut, a so-called barrel vault cut, just proximal to the tibial tubercle, and realigning the leg so that we've gone from a varus alignment to a valgus alignment. The big advantage of a Maquet is you can anteriorly translate the tibia, which allows you to treat osteoarthritis of the patellofemoral joint and realign the forces on the if there is arthritis in the patellofemoral joint. This is a paper I wrote a couple of years ago showing the detailed analysis or detailed description of the Maquet osteotomy with a video. So if anybody wants to look at it in more detail, that's a place to go. Okay, what results can we expect from a properly performed tibial osteotomy? Here's a paper published last month in JBJS. Excuse me. At 10 years, the survivorship, and this is a meta-analysis. This is not a single paper. This is a meta-analysis. And they said there was at least a 3/4 survival at 10 years, and some people reported 97%. At 15 years, you've got 2/3. The results do tend to deteriorate a little bit, but you can still get as much as a 90% survival at 15 years. So not quite as good as a total knee, but if you're talking about younger people, you're talking about a 50 or 55-year-old, you've now brought them up to 65 or 70, where the total knee becomes a really viable option. And obviously you still can put in a total knee at this point. So it's a virgin total knee, it's not a revision. Revision total knees are never as good as the primary total knees. Now, what are x-rays? What are normal alignments? Normal anatomic valgus at the knee is 5 degrees in a male, 2 or 3 degrees in of mechanical valgus. A female, because of the physiologically wider pelvis, has a 7 or 8 degree anatomic valgus, but still 2 or 3 degrees of mechanical valgus. Okay? So, what should we try to achieve? These are studies over the years dating back to Coventry, more recent studies. They're all in the 8 to 10 degree range. There's a couple here. Shoji in 73 said 5. Fletcher said 6, but most recommendations are in the 8 to 10 degree range. That's the anatomic axis. The mechanical axis has a much higher agreement rate. You're talking about 3 degrees, give or take. Now, the more recent studies have tried to measure the mechanical axis in a different way. And these are studies that recommend the 62.5% of the medial to lateral width of the proximal tibia. So what that means is on the left side of the screen, we've got a line from this is the mechanical axis from the femoral head to the ankle. And the line falls in the medial tibial plateau. That means that the weight-bearing forces are going to be concentrated on the medial joint line. Now, the 62.5% means that you measure a point from the medial to the lateral tibial plateau, measure 62.5%, which is lateral to the intercondylar eminence. And here's the demonstration here on a normal knee with normal alignment, but the mechanical axis, this is how this has been devised, that hits 62.5, whoops, I'm sorry, lost it here, goes through the lateral tibial plateau, and that's where this 62.5%. Now, this is the equivalent of 3 degrees of mechanical alignment. So this is just a different line, but it's measuring the same thing. Okay, now, what are the results? Most series, in fact, I've never been able to find one that does not report the alignment as averages. Everybody reports averages. So the Coventry in 93 said if you had greater than 8 degrees of valgus and less than 30% overweight, there was a 94% survival at 10 years. If the correction was less than 8 degrees of valgus or you were over 30%, the survival was now 20%. So maybe tibial osteotomy has gotten its bad name in some circles because of poor surgery, or maybe we just are not accurately measuring our results. Do standing x-rays really accurately predict the clinical results? And that was the purpose of my study. Okay, now let me define, this is the paper, but let me define a few criteria here. The target angle was what I wanted to achieve. This was a prospective, the study was prospective, but it was not consecutive. I did not have x-rays, a full set of x-rays pre and post-operative on every patient. But we defined the target angle as a prospectively determined angle on preoperative x-rays to achieve 5 to 8 degrees in a male and 8 to 10 degrees in a female. So we were trying to overcorrect or restore slightly overcorrect or restore the normal anatomic angle. The planned correction was the degrees between the preoperative angle measured on the standing x-rays and the target angle. The postoperative angle was the angle we actually measured at 6 weeks on full weight bearing x-rays. The actual correction was the difference between the target angle and the postoperative angle, or how much did we miss our target angle? How much did we under or overcorrect our target angle? We had 35 osteotomies, 13 Coventry, 22 Maquet, because I switched to a Maquet years ago. We'll go through things here. The average age is 58, so this is a little younger than your typical total knee population, but there was a 68-year-old. The BMI, the average was 34, but we did a 58. This would obviously 58, I mean, not every university, but some universities will not even touch a total knee with a BMI of over 40. So, excuse me, a heavier individual is an option for a tibial osteotomy. All were full weight bearing at 6 weeks without external support. The average preoperative angle was 5 degrees of Varus, but there was one with 22 degrees, and we had one with a 0. The planned correction averaged almost 14 degrees, but again, one was 33 degrees. All the x-rays were reviewed by a blinded assistant author. I didn't review any of these. Now, there's going to be 6 slides here with the results. This is the individual results, which as I stated, I've never seen an analysis this way. Everybody talks about averages. So the bottom is the preoperative x-ray angle. The top is our target angle. These lines, these arrowheads, are how close we came to our target angle. So down here, we got a 25 degree of Varus. We wanted to go to 10 degrees or 12 degrees of valgus. We almost made it. But you look over here, here's one where we were only 4 or 5 degrees, and we were only looking at 5 degrees. We didn't make it very well. Some of these here, this one, we didn't get anything. We were at 0 pre-op, we were 0 post-op. So some of these are, 50%. Whoops, I'm losing my arrow here. Where's my arrow? Okay, we're losing 50%. Here, we got close to our target angle, but it was a small correction. All right, here's the Coventry. We did pretty well on a lot of them, but here again, here's one with very little correction. Here's one where we had no correction. We ended up, it was 5 degrees of Varus pre-op, and we didn't correct anything at all. So this is where we'll discuss this, but this is the problem with averages. The averages are going to wash out some of your bad results. All right, here's the Maquet. Looks pretty good. We did real well here. The Maquet with you can't correct a 30 degree correction with a Coventry osteotomy. You're just not going to have any bone left to support it. So looks pretty good here. However, here's the one where we didn't get anything any better at all. Here we only corrected to neutral. So again, here's another one where we only corrected to neutral. So the results are not always consistent on x-ray. Here's female. Maybe the gender has something to do with it. Again, here's one where we corrected to neutral, another one to neutral, but close. Here's these look really good. We came close to our target angle here with a 15 degree correction. So it looks good in some cases. In other cases, it's just, it's not anywhere near as good. Here's the male numbers. Again, same thing. Here's one with, where's my arrow? We just corrected it to neutral. We were shooting for 8 degrees. We got to neutral. Same thing, neutral. We missed correcting into valgus. Here's my BMI. Perhaps the BMI affects things. So maybe a very obese person, it's more difficult to correct. We'll talk about things in a minute. One of the ways of determining correction is at surgery. Obviously, you can't take a weight-bearing x-ray at surgery. They're obviously supine. So weight-bearing x-rays in surgery, whatever your x-rays are in surgery may not represent the weight-bearing x-rays that you're getting pre and post-operatively. So one of the potential causes of error is that the measurements, trying to find the anatomic axis or the mechanical axis in surgery may be very difficult. So BMI may compromise your surgical correction. So you can see here at 58, the one morbid obesity, well, more than morbid, we didn't correct at all. That went to 0. But here at 54, we did great, went to 10 degrees. Same thing, another one at 53, we went to our target angle. So obesity with these two, I'm sorry, I said wrong. This one didn't correct at all. Whoops, again, I'm sorry. Okay, so here we had poor correction at 58. These two were poor, but this one was 53, and we got it right on target. This one was 50, and we decent. Here's another one at 45, which still, again, in many circumstances would not be a candidate for total knee because they're over 40, and we were right on. So overall, with the exception of the two extreme morbidly obese people, we did okay. Again, here's one where it was a 29. That would certainly be not considered obese and maybe overweight, and we didn't correct these at all. So overall, BMI may have had some mild effect, but overall it didn't. So overall, osteotomy technique, gender, and preoperative Varus did not affect results. The two largest BMIs were poorly corrected with the Maquet technique, but no apparent difference in any other cases. Statistically, 7 knees were overcorrected by almost 3 degrees. But again, this is where we get into one was 7 degrees, so that kind of skews the overcorrection. Only 3 knees were corrected exactly to the target angle. 24 knees were undercorrected by an average of 3 degrees. But again, this gets skewed by the averages. There was one that was 13 degrees. 2 knees had no change in postoperative x-rays, as we showed. Okay, so overall, only 14 of 35, 40% were corrected to within plus or minus 2 degrees. So we could change this. We could say, okay, plus or minus 3 degrees, 4 degrees, but I think 2 or 3 degrees has been used in the literature as far as what's determined accurately. So that's what I used in the paper. Now, what are the potential explanations for our failure to achieve what we tried? Number one, x-rays are difficult to standardize. As we talked about, you have to, when you're taking full weight bearing x-rays, you have to have the feet pointing forward. You have to try to get the people to stand equally on both sides. Sometimes they're painful. Sometimes they're difficult to simply stand. So if they've got a flexion deformity or they tend to bend their knees, it's difficult to get standard x-rays preoperatively. The question is, should you use full-length x-rays? I did full-length x-rays many times early in the series, and there was just no difference between the anatomical and mechanical axis in terms of the number of degrees that we corrected. So unless there is a tibial or femoral shaft deformity, you don't need to get full-length x-rays. You can get the standard, which requires a special cassette, and you got extra hassles for the radiology technician to take it. This has been studied. There is no difference in the amount of correction that is required whether you use the anatomic or mechanical axis. So while I did do mechanical axis early on for the purposes of the paper, I just did the use the anatomical axis for correction. X-rays don't feel pain, as we talked about. Because of pain, you may not be able to get the X-rays, and the other thing is that you can have severe degenerative changes and relatively little pain, and relatively normal x-rays with severe pain. The biomechanics of standing x-rays are flawed. We may not be reducing the clinic or reproducing the clinical picture. In other words, do standing x-rays really compare to walking, which is obviously what we're trying to achieve. We're trying to get a person walking. This is what I alluded to earlier. How do we measure our correction intraoperatively? How do you determine how much you're going to correct? Are you going to use a template? Are you going to use a mechanical alignment method? Like I said, the Bovie cord method. This is one of the common things where you run a Bovie cord from the anterior superior iliac spine to the center of the ankle. Or you take an x-ray and center the Bovie cord over the head of the femur. But the Bovie cord is obviously not completely straight. You can, if your x-rays are rotated a little bit, you may not get a completely accurate measurement. So this is a problem with, a potential problem with intraoperative measurement of your correction. And finally, maybe we're just not that good. Maybe we don't have the technical wherewithal to accurately make corrections. And perhaps this is where computer navigation is the answer. Okay, so this goes into the biomechanics of normal standing x-rays. Okay, the center of gravity goes down to the floor, and the forces in normal standing go through the femoral head. The weight-bearing forces go through the femoral head, the center of the knee, and the center of the ankle with a 2 or 3 degree correction to the lateral side. This is the mechanical axis, but it is the weight-bearing axis on the femur is parallel to the midline of the body. Now, in single leg stance, obviously you have to unload in this case, the left side to take a step with your left leg. So that means that you're going to shift the center of gravity to the right side, and your gluteus is going to abduct and to keep the left side from falling. That's the mechanism of a Trendelenburg test. If the gluteus medius is weak, the pelvis sags. So in order to lift the left leg off of the ground, the gluteus has to contract because you're no longer putting up forces on the left side. The body is going to shift to the left side, and therefore the center of gravity is going to shift center or medial to the knee. So maybe our x-rays are not measuring a true weight-bearing alignment. Theoretically, in order to bring the mechanical axis in this single leg stance, theoretically, in order to bring the center of gravity over the femoral head and the alignment, you'd have to shift the femoral head to the midline, which is obviously not possible anatomically. And the studies have been done that show that in order to keep the femoral head in the acetabulum and to bring the weight-bearing axis out through the ankle would have to be 25 degrees of valgus, which would be cosmetically just impossible. So it is clear that bilateral standing x-rays excuse me, do not reproduce the biomechanical equivalent of normal walking. Let me digress for 1 second. The Lewinick, Lewinick and Compeer were my professors when I was a resident. The Lewinick safe zone is always talked about in total hips. This is total hips. This is 1976, 77, I think it was. And he defined the Lewinick safe zone as plus or minus 40 degrees of abduction, plus or minus 15 degrees of anteversion. And this is the alignment of the acetabulum. And he said, okay, here's the dislocated hips. Most of them were outside of the Lewinick safe zone, but you see a lot of these that were outside but did not dislocate. So this has been called the safe zone, and it has been criticized both at the initial paper and subsequently, but this is what, despite the criticism, this is what everybody shoots for on a total hip. Okay, 40 or 45 degrees of abduction, 15 degrees of anteversion. And, but this is, was originally described as what you could prevent total hips or total hip dislocation. Now, the Mayo Clinic did almost 10,000. They had 2% dislocations, but 58% of them were still in the Lewinick safe zone. So clearly, x-rays in the total hips do not prevent a major complication such as dislocation. So you can see here's the dislocated hips within the center. So here again, x-rays may not reproduce the clinical situation, and we should be cautious about, at least potentially cautious about taking too much emphasis on x-ray alignment. Where's what happened to my arrow here? Well, anyway, okay, whoops. Okay, lost my arrow. Here it is. Okay, all right. So here's one of my patients. 6 degree of Varus preoperatively. We planned a correction of 12 degrees. Okay, here's the other knee. You can see he's got almost 0 at this side. You can say there's probably a little bit of narrowing here, a couple degrees. So he's at 0 degrees on the left knee. This is again the anatomic axis. So we got 6 degrees of Varus, 75% medial joint line narrowing. Here's my postoperative correction. Here's my barrel vault osteotomy, the lateral plate. Okay, and we have little, if any, correction. We got maybe a degree or two of correction on standard weight-bearing x-rays, okay? We got 1 degree of valgus. Now, here's what I did. I thought, well, maybe I've made my correction, but the weight-bearing x-ray is not the standard bilateral weight-bearing X-ray is not reproducing my correction. So I said, well, a single leg stance is obviously for walking. How about if we put a stress on the knee and see what our correction is if we have weight-bearing stresses or valgus alignment stresses, what we're trying to achieve. So here it is. If I put stress on it, our correction is absolutely accurate. We were 1 degree off. So obviously the weight-bearing bilateral X-ray is not reproducing our physiologic situation. So I corrected it. My surgery was accurate, but it's just bilateral standing X-rays don't reproduce the normal walking state. Okay, now we talked about computers. Maybe computers are the way to go. Obviously, computers solve every problem. This is a study from 2009, 50 conventional, 50 computer navigated. This is the Brain Lab. Now, we can also argue that this was an old series. Maybe we're more accurate, but the computer was significantly more accurate and lower dispersion, meaning that the results were not as far out of whack. There was no 10 or 15 degree errors. The mean error was plus or minus 3 degrees. There was with 3 degrees as the criteria, there was 50% within plus or minus 3 degrees conventional instrumentation and 96% computerized. But the conventional was measured by the Bovicord method. So was this was the computer simply being more accurate, or was there some other explanation for things? Well, that was just a radiologic study. Here's a computer navigated study, 75 computer navigated, 75 conventional. The 10-year survival was 89.6% with 2 total knees in the computer and 1 in the conventional. So the computer was actually slightly worse. There was no significant difference in clinical results, whether you use the computer or you use conventional technique. So again, we get into the aspect of things. What are we measuring with x-rays? Does it really make any difference? Clearly x-rays have wide variability, but it doesn't appear to be significantly different in terms of clinical results. So take-home message. Using the technique we've used for 70 years, back to the 1950s, most of your patients will do well. Use radiographic measurements to try to correct things as close to historical standards and criteria as we can, but don't worry too much about the postoperative x-rays. You're looking for healing, but most of your patients will do just well. We obviously have not solved the problem of why some tibial osteotomies will fail. It does not appear to be radiologic criteria. So, questions?
Right. I would like to thank Professor Klaud Miller for a very illuminating lecture. It just reminds me of the long-term motto in medicine that you treat the patient and not the X-ray.